Hi, good morning. So we're going to move over to the debate number 2, where to draw the line for focal therapy versus whole gland treatment for PGG 2 and 3 disease. And we're going to start off with the pro-focal therapy discussion by Dr. Rafael Sanchez Salas.
Good morning, everybody. So we're going to overlap a little bit, or perhaps a lot, in terms of the evaluation, and I'm going to advocate for focal therapy. Thank you very much for the opportunity. My disclosures. So I'm going to be discussing against Dr. Bianco. This is the first thought that I had in my mind when I had this news. Dr. Bianco, the bull Bianco. And this is the person that you don't want to discuss with. I know him from many years ago, and that was my first vision of the situation. And then I have this is probably what I should do, but I guess I'm going to take the task and try to show him that focal therapy is much better. As a matter of fact, this is a Focal Therapy Society meeting, right? So, radical prostatectomy. This is from many years ago. Dr. Bianco was a very young, promising uro-oncologist, and you have, even then, he had very clear the surgical technique, surgeon experience, patient selection was the most important, the most important variables to reach success. And success is not only cancer control, but the evaluation of urinary incontinence and the impacts of obviously on potency. Trifecta. First papers on trifecta, there's some controversies of who defined the trifecta, but Dr. Bianco knew already how important it was. So I will advocate today for a disruptive and controversial option, which is focal therapy, a technique that is in high demand from patient side. The number of patients and publications is on the rising, and moreover, is related to quality of life preservation, which is essential today. So what we expect from focal therapy is first a very detailed stratification, a diagnosis. If ever focal therapy doesn't move forward in the uro-oncology field, which is very unlikely, the stratification that we are getting from focal therapy evaluation is very unique, and it has definitely improved the way we look at prostate cancer. So we aim to eradicate these lesions. We will spur non-cancerous portion of the gland. That will translate into improved functional outcomes. We will treat the entire organ if this becomes necessary, or we can even retreat if needed. But focal therapy is a treatment process. It's a treatment process in which, as said previously this morning, it's based on risk assessment to improve function. So the risk evaluation starts at the clinic when we see the patient first time, during treatment, and in follow-up. It's risk assessment with a clear objective, cancer control and preservation of outcomes. We heard Dr. Tanella yesterday on the index lesion, and we know how this principal focus of carcinoma can drive the disease. It has been proven more recently in the radiotherapy area. And we know that there are different options for the treatment. When you look at the panorama of prostate cancer, there's this well-known dichotomy, active surveillance or aggressive radical treatment, and we know the focal therapy is perfectly fitted for the 3+4 and the 4+3. How we know this? This is the Bill Axelson study that was clearly discussed yesterday. We know that the metastatic potential of eventual progression for these patients harboring Gleason 3+4 and 3+3 is limited, and is not as important as we thought at some point. On the top of that, this is the Hoffman study showing in the Pentagon plot how sexual function, hormone function, bowel function, all of those parameters are not very good when you look at the outcomes and you compare them with the active surveillance counterpart. So how are we going to select these patients? This is the Nasiri study of close to 500 patients that were evaluated, and based on NCCI criteria, we have a selection of patients that can include as high as patients harboring 4+3, with PSA 20, multiparametric MRI with at least lesions PIRAS 3, and we see that 1 out of 3 men is eligible for focal therapy. This is following NCCI guidelines. So multiparametric MRI, the cornerstone, will define an ideal candidate. They need to be assessed with an ideal biopsy. This, in my thinking, this is a transperineal fusion biopsy, including systematic assessment. And with that, you have an accuracy of around 75% when you select these patients. And this is what happened. And you have a recent series, like the one from Memorial Sloan Kettering, Befaraday, showing a number of patients treated with HIFU, and this is inclusion, exclusive inclusion of patients 2 and 3, ESOP 2 and 3, with a time of preservation of the quality control outcomes in terms of cancer control and potency and continency that is very, very good, as acceptable. When you look at the evidence of the actual clinically significant disease is very limited in the study. But we thought about randomized control trials. There's a randomized control trial that was done initially in the Netherlands, in Europe. Dr. De La Rosette led this work, and they compare a more limited evaluation, assessment in terms of exposing to energy to a hemiablation, and what we have is comparable cancer control with men with localized prostate cancer, either low or intermediate. At this point, we need to understand that intermediate is not necessarily the best way to go. Low is not the best indication for patients with indication of focal therapy. So we need to talk about whole gland ablation. Whole gland ablation, this is a very nice work by Streetham that is showing the recurrence-free survival, the overall survival. This is a best statement for practice from the Focal Therapy Society. We have the functional outcomes. This is whole gland ablation. When we compare whole gland ablation, we know that the strong recommendations for the deployment of this are patients harboring intermediate prostate cancer, but not willing to undergo either surgery or radiotherapy, and definitely not candidates for focal therapy. When you compare whole gland ablation versus focal ablation, we see there is adequate control in terms of cancer, and promising, at least in 2019, there was a promising results in terms of the treatment with preservation of functional outcomes. These are our series from Paris when I was there, and you look at this follow-up at 1 year, 3 years, 5 years, metastasis-free survival, which is a very important parameter, is very limited. Without retreatment-free survival at 5 years, they can be as high as 67%. With this information, we look at the comparison of whole gland ablation versus focal ablation, and we see that potency for both potency and continence, there was a focal therapy was the most important factor related with the preservation of those parameters. So cancer control can be achieved, functional outcomes are preserved. In the same, there's a more recent series, this time with HIFU, that is showing, once again, preservation of functional outcomes when you do focal therapy, and you compare that with whole gland ablation with adequate non-residual cancer detection, completely comparable between the two arms. If you compare with surgery, this is our series from Paris. Continence and potency were once again preserved with a focal therapy failure of around 28% in that series. And we all know this paper coming out of London that is showing that at 8 years follow-up with a majority of patients harboring Gleason 3+4, the patients are having results that are completely comparable in terms of cancer control outcomes when you compare with radical prostatectomy. So this is the partial gland ablation in the making. When you look at the timeline to adopt focal for breast cancer, you see there is a line from pioneers, early adopters, randomized controlled trials. In the line of development, there is no way back to do whole gland ablation. And this is what we need to understand. In order to move forward, we cannot try to stop and rethink about whole gland ablation. Prostatic microenvironment is essential. This is what happened because even if we do a perfect hemiablation, we will create inflammation within the prostate that might end up changing the natural history of those lesions that are not necessarily aggressive, but they can become aggressive due to the inflammation exposure. This is the FLAME trial. The FLAME trial is radiotherapy, and this is telling us the whole gland perhaps is not over. In the FLAME trial, they did a focal boost in the prostatic lesion, proving that the actual index lesion hypothesis is real, as we would think. And this trial is showing the adequate cancer control outcomes with a preservation of the toxicity. In our side, you have seen this, the presentation from yesterday, the radiation, the air tire is a combination of IRE and radiation therapy. You hear Dr. McClure in his presentations yesterday, very promising combination, symbiotic combination of energies plus something else. Energies plus low-grade radiotherapy, in this case, energy plus systemic treatment in order to make the field evolve, because as I said previously, the grenade inside the prostate will not, most likely will not be able to reach the success we expect. So in conclusion, we understand that the index ablation of the prostatic cancer, the index ablation of this, the ablation of the index lesion will improve the cancer control and will above all keep up with functional outcomes. In ideal patients, 3+4 and 4+3, and there's an improved selection, evaluation of risk, and evaluation of prostatic microenvironment in order to make the field move forward. Thank you very much. I apologize for.
Rafael, I congratulate you on your many contributions to this field. You introduced a term today that I had not heard before, and that was to think of focal therapy as a treatment process. And I think that's exactly the right way to think of this. This is a marathon, not a sprint, and it's a journey. And that's the message we have to get across to our patients right up front in selecting people for focal therapy. Congratulations.
Thank you, Dr. Marcus.
One other question for the audience would be, can you define your opinions about multifocality versus unilaterality and unifocality? Which is your most stringent recommendation for the focal candidate?
I think we starting a program, you need to go for unilateral lesions. Multifocality, you cannot definitely perfectly account for, but that's why I have this idea, and this is something that we had several discussions in Paris, is about adding something else. Energy plus something else should account for multifocality, but at the beginning, you should not be treating bilateral lesions for sure.
Okay.
Thank you.
Next, we'll have Dr. Fernando Bianco, who will speak about pro-whole gland.
Gentlemen, members, and guests. So when Dr. Polasek asked me to take the pro side here, you know, it's kind of like, how many of you are doing robotic radical prostatectomies? Okay, so we have a good crowd. So interesting. So for me, it was like an act of contrition, of atonement, try to think, well, I still do about this operation roughly 5 to 10 times a month. And who should we do it on? These are my disclosures that I had presented also before. And so we're going to talk about evidence-based medicine and, again, cherry picking or patient selection and follow-up. So I start with this study, or this proposal really reflected by Dr. Klotz and the group there, Dr. Egener and Cooperberg, among others, on the models of cancer progression, the typical Hallstadian model, the belief, you know, it came out of Sloan Kettering. That's how we think about prostate cancer, that you can definitively interrupt the natural history of the disease. And then the Fisherian model, where micromets may determine the outcome of the disease. The premise of why radical prostatectomy is definitive by means of arresting the progression of the disease is supported by the fact that with the early screening and implementation of radical prostatectomy, the nerve-sparing technique proposed by Dr. Walsh, we did observe a significant decrease in mortality rates associated with prostate cancer, which was not really seen in the breast cancer models over time. no cancer is the same, but there's definitely evidence that by taking the prostate out, you can really interrupt the progression of this disease if you do it on time. So what is the evidence telling us? Well, we have now 3 studies. I think Dr. Gill did a phenomenal job yesterday going over them. And I just want to stress a couple of the findings for intermediate risk, which is what we're addressing in this debate today, or Gleason 3 plus 4 plus 3. There is a definitive changes in how people die from the disease or not, whether they were watched or they were treated with prostate cancer, and also a decrease in the major determinant of survival and why there's no survival difference, which is the implementation of hormonal deprivation therapy associated to the surgical room. This is even more evident for patients who have PSAs between 10 and 20, which unfortunately were the vast minority of patients in all the large series done open and or laparoscopic and or robotic. So again, the case is that if you have intermediate risk, that's where surgery will make a bigger difference. And also, if you're young, this is what the Swedish study showed, there will be a higher benefit in survival. So the 3 lessons, I think, from those randomized studies were do not operate in Gleason grade 1, do not operate really in men older than 70, you're not really going to impact them. And again, but in intermediate risk, you should strongly consider. On the other hand, Rafael showed a lot of the studies that are going on focal therapy, and we have our contributions, and this meeting has been full of that. But however, the data is not as robust, and hopefully as those studies mature, it will get there, and we're all working towards that end. But the thing is that there's a lot of uncertainty around, and when we're dealing with a younger man, I will propose, we have to think in the context of what happens if they fail focal therapy and what happens with those functional outcomes after that. Because clearly, in the beginning, there's no comparison between open and focal in terms of functional outcomes. In the focal world, there's no trifecta because people don't really lose continence and very few lose erections. They actually improve urinary function early on. And Rafael alluded to the study by Bafar at Memorial and, a series that they reviewed where one of the pitfalls of focal therapy is how you treat, whether you should be treating Gleason 6 or not, and how those series are composed and the recurrence rates and how do you handle it. I would agree with some of that. So how do we cherry pick better? Well, we know cancer is a pluripotential disease. Histology is important. And race and age are important right now because the data is maturing. And if you are of African American or ethnicity, you're more likely to have an aggressive prostate cancer than not. The other point that is critical and has been emerging over the last few years is the type of genetic mutations that you may have, whether it's germline or somatic. If they're germline, bottom line, they do pass across your descendants. So it's important to distinguish the people who has germline mutations because if they have the BRCA gene, you're not going to treat that focally. These tumors will come back. And they will metastasize, and people may die from that. The model in that case might not be the cancer, I say, can escape you. So if you have these germline mutations, it's important to probably arrest the disease when you can or when it's necessary and not wait around or have the patient. So who are those patients? Well, they're about 10 to 15%. So a strong family history is clearly critical nowadays, and you need to identify also if they're Ashkenazi origin and Jewish, they clearly have these mutations above average in the population. If they have first degree relative, it's important, or history of breast cancer in the family as well, or history of colon urothelial with more than 3 parental familiar family members. That's all key. And there are several panels that can use today to do this. The other limitations when we address focal therapy, they're not when you do technically a radicals, is everything that we were discussing, whether you should treat unilateral, multifocality. I do think with focal you can address multifocality and not in the definition of focal therapy, whether it has to be hemiablation or not. But like the study of Samir showed that the MRI tends to underestimate the tumors. We know by the PROMISE study that about 25% of those tumors are not seen on the MRI images, and the study by Johnson that pretty much validates what Promise said. How you do a biopsy and the information that the biopsy gives you is critical. For a lot of people, a biopsy is whether you have cancer or you don't have cancer. I believe you need to know where is the cancer, but also you need to know where it's not if you're going to treat this under focal. If you are thinking about just removing the gland, you just need to know there's cancer, period. But otherwise, how you do the biopsy is going to impact how that focal therapy may be performed and how eventually that patient may respond or not. And then it's the problem, the eternal problem of upgrading, and that we can see between the biopsy series and the radical series. And this is a well-noted phenomenon that instead of getting better over time, it has gotten worse. And Dr. Sanchez might say, well, you know, but we're now doing fusion biopsies, so we know better. Problem with is how we grade them, right? I mean, you may have a biopsy that has 6 core positive, of which one is 3+4 and the other ones are 3+3, and that patient gets labeled the same way that, you know, someone that may have, 6 of them 3+4. And what's the impact? I mean, that's research to be done. But anyway, even in the fusion biopsy era, we still have at least a quarter of the patients who get upgraded if you remove their prostates. Dr. Mark's group, you know, they did this the elegant study on looking at what could be the eligibility, thinking or defining focal therapy as hemiablation and the presence of tumors on the contralateral lobes. And they could see that about a third of patients were truly eligible for focal based on this premise that they only had unifocal tumors. And that's consistent with the fact that about 75% of prostate cancers are really multifocal. So if you are concerned about multifocality, then removing the prostate is your best option. And finally, you know, the PSA test was really approved by the FDA in 1986 as a biomarker to monitor prostate cancer recurrence. And it's definitive when you do surgery. It's black and white, it's easy. You do it every 3 months or 4 months in the first year, every 6 months, up to 5 years, and then you forget about it. You don't need of MRIs, you don't need of much stuff. It's easy, it's a blood test. In the focal world, you need to do a lot. We're talking today about PSMA scans, about MRIs, about all kinds of things. So in many ways, the follow-up is less costly and stringent when you remove the prostate. And if you have a recurrence, you know you have a recurrence. You're not speculating around. So I think that the indications today for surgery are, if you are very young, surgery should be the option. We don't have 20 or 30-year data on focal therapy to really judge this. And if you're younger, 60, 65, but you have germline mutations, there's an absence of correlation between MRI and the biopsy path, or you have the bad words of cribriform or ductal in the histology, you got to be very careful. Sure, you can treat it maybe with focal, but this can come back to haunt you. I always try to think about treating my patients just if I did myself. If I had that kind of prostate cancer, I'll probably get my prostate out. If someone has poor erections, then you know we have to measure the trade-offs. Really, what are we going to gain by really the focal? If it's a younger person, I mean, continence outcomes after surgery, after all, they're not as good as focal, but they're not terrible, done in surgeons who know what they're doing. And if you have a patient who is exhibiting poor compliance, I think it's better to take it out than wait till the bomb drops. So with that said, thank you very much. I rest my case.
Fernando, another great job. You've done a really nice job of putting into perspective that we're going to have failures with focal therapy. It's not going to be 100%. You've got to tell patients this in advance. And what's amazing to me is how forgiving these patients are if you failed with your first attempt at focal therapy. It's not a disaster. And it's something that has to be presented to the patient right up front in their choice of treatment selection. So nice work. Thank you.
Thank you. Thank you very much.